All right, so this is part two for diffuse proliferative lung disease, as well as occupational lung disease. We kind of already went through, for understanding diffusion limitation of interstitial lung disease, we already went through what a secondary pulmonary lobule is, which is going to help us interpret CT scans. We already went through the differential diagnosis of interstitial lung disease, or sorry, diffuse proliferative lung disease, which is, things that can give you ground glass opacities, things that can give you interlobular thickening, or things like heart failure, malignancy, as well as infections. So, make sure to consider those diagnoses before you consider a diagnosis of diffuse proliferative lung disease, depending on which one you're looking at. So that was end of part one. Moving on to part two. So we'll start off to make this active learning. Start and do the question, except 19, pulmonary question 33. And this question, kind of tangled up the cords here. All right, so this question really goes into our idiopathic diffuse proliferative lung diseases. So I will say these took a long time for me to understand. And what really idiopathic diffuse proliferative lung diseases are, these are not disease entities in and of themselves. These are disease entities that are based on not just a radiographic, but more of a histological pattern. They kind of give you a diagnosis based on imaging and or biopsy, and that give you a differential diagnosis based on imaging and biopsy of the CT scan, plus minus doing an actual biopsy and look at it histologically, and that gives you a differential diagnosis of what diseases could call it. It's almost like a little bit similar to nephrotic syndromes, and nephritic syndrome, and finding, let's say, rapidly progressive RPGN, rapidly progressive glomerulonephritis, and it kind of gives you a differential diagnosis instead of being a disease in and of itself. So this one, I'll kind of go over to the two big idiopathic diffuse proliferative lung diseases. One is going to be NSIP, which is non-specific interstitial pneumonia. The other one's going to be UIP, which is usual interstitial pneumonia. So this question was really on UIP. And usual interstitial pneumonia. This is, in general, caused by an aberrant wound healing response to injury. So some of these patients with UIP get an injury at some point to the alveoli, to their interstitial, and they respond actually with complete destruction of their secondary pulmonary lobule unit, and then they eventually will have cystic formation. So when you do a CT scan with these patients for UIP, what you're really going to see is pretty severe fibrosis. So we're looking at the lower lobes here. You can see things such as fibrosis, which is causing outward pulling of your bronchi. So you can have traction bronchiectasis, right, which is bronchiectasis secondary to traction by fibrosis and subsequent bronchial widening. And the other big thing really to make the diagnosis of UIP, usual interstitial pneumonia, is going to be seeing these honeycombing spaces. And what these honeycombing spaces is basically complete architectural destruction and distortion of a patient who has a fibrotic response, either due to IPF, delayed senescence in older age, or fibrotic response to things like GERD or smoking, or it can also be due to other findings as well. So UIP is this kind of radiographic fibrotic finding that we see with honeycombing, traction bronchiectasis, and fibrosis on CT scan. When you rule out secondary causes of it, so secondary causes of interstitial pulmonary fibrosis is going to be hypersensitivity pneumonitis. Long-term exposure to things like asbestos can cause fibrosis of the lungs. Drugs, we went over some drugs in the previous lecture, but someone maybe who takes has recurrent UTIs and takes drugs for that, or is taking methotrexate or is on amiodarone, nitrofurantoin, they can get fibrotic lung disease. And the ones that can cause fibrotic lung disease as well would be systemic sclerosis. This one makes a lot of sense. Systemic sclerosis is thought to be maybe initiated by a fibrotic viral fibrotic response to some sort of viral pathogen. Sometimes maybe it's CMV. But anyway, this is an autoimmune response that has proliferation of cytokines by fibroblasts, things like TGF-beta, PDGF, a lot of those growth factors that cause subsequent college deposition and whole body sclerosis. This one makes a lot of sense. They can get fibrotic lung disease. RA, kind of just have to memorize this one. So when you rule these out, then you can kind of rule them out just with clinical manifestations, CT findings. You don't always need a biopsy. Biopsy is also a little bit dangerous in these patients. Imagine putting a needle into a fibrotic lung. It's much more easy to puncture, and they're unable to heal where you kind of put that needle into. Oh, sorry. Here's the, these patients. So when you rule these things out with CT findings, radiograph findings, you do this workup for hypersensitivity pneumonitis. You ask about exposures with pneumoconiosis, hypersensitivity pneumonitis. You ask about drug use. Have they been on a drug that's known to cause pulmonary fibrosis? Do they have signs and symptoms of RA, systemic sclerosis? When you really rule all those out, you can get the diagnosis of IPF. So IPF, what is this? Similar to UIP, this is aberrant wound healing response to pneumocyte injury, right? So these patients get severe fibrosis of their secondary pulmonary lobules and pretty much complete architectural destruction. On histology, you can kind of see here, here's these normal alveolar spaces, here's a bronchiole, so here's a blood vessel here. What you see in histology is really this complete fibrotic response and destruction of your secondary pulmonary lobule. So here's all this destruction here. Here's basically a relatively low-powered picture of honeycombing with more normal alveoli here. And what that looks on CT scan, we kind of went over. Here's a pretty severe case. It's going to be more basal predominant, more on the peripheries where you're going to get honeycombing. I think even make the diagnosis of honeycombing, you have to see at least 2 layers of this fibrotic dilated response here. So here's kind of honeycombing here, which responds to just complete architectural distortion by fibrosis of the secondary pulmonary lobule. And like I said earlier, CT findings, you might see that traction bronchiectasis as well from traction from the fibrosis, making those bronchioles a little bit larger. Things you might find on exam for these patients, so they do have fibroblast activation, and those fibroblasts here secrete things like TGF, PDGF. TGF is transforming growth factor. PDGF is platelet-derived growth factor. Not only can this cause fibrosis in the lungs, this can cause collagen deposition in the fingers as well from release of these cytokines. So these patients may have clubbing, and clubbing is something you're going to see in IPF. You really shouldn't see it in asthma and COPD. You can see it in things that cause lung shunting. In those cases, it's more likely due to platelet clumping that's not cleared by going through the pulmonary capillaries, and they go to the left side of the body, deposit the fingertips for these PDGF and cause clubbing that way. So that's kind of one of the differential, but these patients will have lung clubbing. They also have these really pathognomonic Velcro crackles, and the reason why they have pretty severe fibrosis of their alveoli here, these alveoli collapse, and then there's different fibrosis amount for each alveoli, so they open up at different pressures. So a lot of times they'll have kind of almost continuous or mid to late inspiratory crackles, and crackles in general are just that quick opening up of those alveoli that had subsequently collapsed from their fibrosis. So that's something you might find on exam. If you hear it once, find a patient in the hospital. Once you hear it for the first time, you'll really never forget it. And diagnosis, I kind of went through this already when talking about UIP, but history, clinical findings obviously are important, plus CT scan, plus rule out other disorders that we kind of went over, hypersensitivity pneumonitis, as well as autoimmune disorders, especially systemic sclerosis, as well as drugs, things like nitrofurantoin, long-term methotrexate, chemotherapeutic agents. It can cause lung fibrosis. Amiodarone is a big one as well. All right, so that kind of gets into IPF, and remember that UIP is really this CT and histological findings, but can have a lot of different causes when you roll out all those secondary causes that we went over, and you can do that without a lung biopsy. So not always necessary. You can make the diagnosis of IPS, which is idiopathic pulmonary fibrosis. With that, do question 19, except 19, question 30. And this one question really goes in to what is the treatment of idiopathic pulmonary fibrosis, right? So we went over this already, that really this is an aberrant, IPF is really an aberrant wound healing response in response to pneumocyte injury. So these patients may be smokers previously, some even have GERD as well, or chronic aspiration, things that damage it. It's really about this aberrant wound response, and they have these fibroblasts are secreting a lot of these growth factors, right? So there's transforming growth factor, PDGFR, all these are going to increase, PDGF, which is platelet growth factor. All these are increasing all this fibrin deposition that you see here, and complete architectural destruction, subsequent honeycombing on the CT scan. So treatment, initially it was thought maybe we immunosuppress these patients, we give them steroids, as well as a DMARD, and they'll get better, but it's really been shown that those do not work. So the treatment for these cases now is really going to be antifibrotic agents. So there's really two of them. I'm probably butchering how to pronounce them. I think about Nintendo, nintedanib, and pirfenidone. All right. So what these do, these are really antifibrotic agents. So nintedanib is a tyrosine kinase inhibitor, secondary, which is a secondary messenger system, and increases cytokine formation. So what that's going to do is decrease things like transforming growth factor beta as well, and you decrease the subsequent colon deposition with this too. Pirfenidone is a direct fibroblast inhibitor as well, so it decreases fibroblast proliferation as well as really decreasing some of these growth factors as well. These can so once someone has fibrosis of the lungs, you can't really get rid of that fibrosis, right? It's there. There's not a lot of cells there that can grow and proliferate. It's not really going anywhere. So these are not going to cure the patient. They're just going to decrease the progression of their lung function, but they do have side effects: nausea, vomiting, diarrhea, anorexia. Pirfenidone, I think, has some photosensitivity as well. So other things you always have to think about is supplemental oxygen if needed, if they meet criteria for that, less than or equal to 88% or 89% if they have pulmonary hypertension. Make sure they're up on their vaccines, especially pneumovax, COVID, flu. They can have really severe outcomes if they get subsequent infections in the setting of having a really poor pulmonary reserve. And really curative therapy is only going to be a lung transplant. The older the patient is, the more comorbidities that they have, especially if they have cancer. This is going to be less of an avenue. And those patients, you let's have goals of care conversation as putting someone with this disease that's progressive and severe. Make sure you talked about them and make sure you get their goals of care, because there isn't a good amount of improvement or good outcomes when these patients get on ventilators, obviously. So make sure you're having goals of care with these patients along, and if it's within their goals of care, things like DNR, DNI, hospice, and things, making sure they have obviously full pulmonary for this. If they're young, they don't have a lot of comorbidities, lung transplant is going to be more efficacious, and it's going to be associated with better outcomes as well. It's really only curative therapy for these patients. All right, so that's IPF. Next one. This is a mixed-up 18 question. I don't know what the question was called, but I'll give you the case. I'll give you a case of a patient I saw in the hospital. He had a history of ulcerative colitis. He kept coming to the hospital over and over again with fevers, constitutional symptoms, as well as CT findings with these consolidations that are longer fibrovascular bundles here. And he's been treated with pneumonia over and over again, but really hasn't got that much improvement with it on this admission from a pneumonia with antibiotics. And the thought is that maybe he has another of these maybe he has another one of these idiopathic diffuse proliferative lung diseases. So which one could he have? Does he have pneumonia? And it's just maybe you're not treating the right organism. Could he have diffuse interstitial pneumonia? Could he have idiopathic pulmonary fibrosis? Or could he have acute HIV? All right. No, sorry. Desquamative interstitial pneumonia, DIP. All right. And this case, so we went through UIP already, but this case, it's really going to be COP, so cryptogenic organizing pneumonia. So really, what is COP? So a lot of people can get organizing pneumonia, things like drugs, radiation, connective tissue disease. These things can really go ahead and cause this fibro-inflammatory response, and this fibro-inflammatory response leads to very fibrin deposition within your airways. So it can be within your airways, within the alveoli itself. When these alveoli are completely filled, the airways are completely filled. You're going to get something that looks basically like pneumonia with consolidations, right? So if you have complete alveolar filling, you're going to have consolidations. There's not going to be much air left in that lung. So on a CT scan, there's not going to be able to see the architecture behind it. If you can't see the architecture behind it, that's a consolidation. If you can see the architecture behind it, that is going to be someone that has ground glass opacities. So what this looks like on these patients' histology is this. So you can kind of see this fibrin infiltrate, and it's infiltrating basically all of the airways, causing these consolidations. These patients a lot of times will present like pneumonia, right? They'll have constitutional symptoms, feverish chills, as well as hypoxia, and subsequently they'll be treated like pneumonia over and over again, but they won't really get better from antibiotics, because in this case it's likely some autoimmune inflammatory response that's happening within these airways with subsequent fibrin deposition. So diagnosis, there's a lot of secondary cause of pneumonia, of organizing pneumonia. Drugs can do it, infections can do it, autoimmune diseases can do it. BAL is going to help you differentiate those. And really, though, the patient that I saw, he was probably a little bit too risky to undergo a biopsy, so we just treated this patient with steroids. But if the patient can undergo a biopsy, that's going to be really the best to rule out things like infections, eosinophilic pneumonia, as well. Yeah, so that's COP, BOOP. The other thing that was on this differential here was, let's see, AIP. Oh, I didn't put AIP on here. But what is AIP? And hopefully we'll go into NSIP as well. So AIP, this is a clinical syndrome of ARDS, right? So these patients have ARDS, and just like ARDS, these patients are going to have diffuse alveolar damage. So here's that diffuse alveolar damage. There's probably an autoimmune response that's just affecting the pneumocytes and damaging those airways. And when you damage that diffuse alveolar damage, you get that proteinaceous buildup, right? So here's all that proteinaceous buildup in your airways. You get death of pneumocytes, you get loss of surfactant. So what you might see on your CT scan with anyone with ARDS could be ground glass opacity consolidations, and specifically due to surfactant loss, you can get atelectasis of those lower lobes as well, with consolidations of those lower lobes from surfactant loss and alveolar collapse. So basically, it is ARDS of an unknown cause. It has all the same histopathological and CT findings of ARDS. You're just not finding something like sepsis, aspiration, obstetric complications that are causing this ARDS. Treatment, this data is pretty limited. These patients should be on high-dose steroids, and then really anyone with ARDS of unknown cause. Pneumonia is also in your differential, so broad-spectrum antibiotics. Probably it's just not a rare disease. It's not a common disease, so they probably just don't have a lot of data on it. It's probably pretty hard to really diagnose as well. So there's really not much data, but it's presumed to be an autoimmune diffuse alveolar damage and treat with hydrosteroids is kind of how you would subsequently go about that. All right. Lastly, do mix-up 19, pulmonary question 20. All right, and this one really gets to your smoking associated idiopathic diffuse parenchymal lung diseases. So the ones that we think of RB-ILD, DIP. So RB-ILD is respiratory bronchiolitis, interstitial lung disease, and DIP is desquamative interstitial pneumonia. So what is the cause of these? It's not exactly known, but the thought process is at least is that smoking goes into your airways, and then when smoking goes into your airways, what happens is that you need something to clear it. So what clears it? It's going to be macrophages. Macrophages to clear it, they take up a lot of these abnormalities from the smoking, and they can also cause subsequent inflammation. Where that inflammation is happening really is going to be the difference between respiratory bronchiolitis, ILD, versus desquamative interstitial pneumonia. If that inflammation, the macrophage inflammation, is really happening in the airways, so it's happening here with those pigmented macrophages, what you're going to get is going to be kind of clogging of the airways with those macrophages here. And this is kind of what you see. There's a bunch of smoker macrophages that are clogging up your airways, really your terminal bronchioles here. And when they clog up those terminal bronchioles, what you're going to see is central lobular nodules, right? So they're clogging up the center of the secondary pulmonary lobule by clogging up those bronchioles. So you're going to see central pulmonary lobules. The differential diagnosis here is pretty wide. You can still see this in like things like viral pneumonia as well. So you may need to try to rule that out. If those smokers' macrophages that are trying to clear up all this nasty and inhaled things like tar and other substance, they're trying to clear that up and they cause subsequent inflammation of your alveoli, then you can have complete replacement of your alveoli. And instead of seeing secondary pulmonary lobules, because it's causing alveolar filling, you're going to see ground glass opacities, as well as you can subsequently see consolidations here. So this is more an alveolar filling process, or alveolar inflammation process, at least, of your of those pigmented macrophages. So what you're going to see is these ground glass opacities, or subsequently, if it's full filling, you may even see consolidations. Treatment, obviously, especially with RB-ILD, there's going to be smoking cessation. Because there's an inflammatory component, you may need steroids as well. Lastly, the last one that we did not go over before we move on and move away from the idiopathic diffuse parenchymal lung disease is going to be NSIP. NSIP is probably one of the more common ones. What's happening with NSIP is that there's some sort of inflammatory, likely T-cell mediated response in the lungs. This could be due to connective tissue disease, things like lupus, HIV. It could be due by drugs as well, all the ones that we kind of previously mentioned. What's happening here? So here's your normal alveoli here, and you're getting alveolar inflammation, right? So this alveoli get thickened. You can see all this lymphocytic infiltrate in the alveolar walls. That alveolar thickening and inflammation really is a bit too hard for a CT scan to see. So what it shows up with on a CT scan is going to be ground glass opacities, and you can kind of see ground glass opacities in the bases here. Subsequently, these patients can get a little bit of like fibrosis and reticular changes, and even in some cases they can get traction bronchiectasis. But what you really will not see in patients with NSIP and how it differentiates from UIP, there is not complete architectural distortion and destruction, so you're not going to see that honeycombing. Diagnosis of NSIP can be made without biopsy. If someone with lupus, let's say, comes in with hypoxia, you rule out let's say pneumonia, heart failure, which can all both cause ground glass opacities. You can really kind of make that like diagnosis of NSIP and can subsequently treat. Now, going over most of these, almost all of these treatments in some way, shape, or form are responsive to steroids. NSIP is mostly like a lymphocytic inflammatory response that can be incited by multiple factors. AIP is thought to be like an autoimmune attack of your alveoli, causing diffuse alveolar damage. COP-BOOP is a fibroinflammatory response secondary to inflammation, and smoking-associated ILD is at least thought by these smokers' macrophages. And that's one thing I didn't mention when going over smoking-associated ILD is that you will probably find these pigmented macrophages on BAL or subsequently on biopsy. If you pursue that, you don't always need to pursue that, which is kind of a hallmark of that disease, but inflammation secondary to the smoker's macrophages. All these respond to steroids. NSIP responds to steroids, AIP responds to steroids, COP-BOOP responds to steroids, and smoking-associated RB-ILD does. UIP, if it's secondary to an autoimmune disease, may respond to steroids, but if you really think it's idiopathic pulmonary fibrosis, steroids actually increases mortality, so you don't want to use those. All right, so those are kind of your idiopathic diffuse parenchymal lung disease, all with different histopathological changes. Here with NSIP, with alveolar septal inflammation, they can subsequently get fibrosis, but they will not get complete architectural distortion like you see with UIP, which is a abnormal fibrotic response to damage in the lungs. Complete architectural distortion, the hallmark of this is going to be that honeycombing, which is just complete destruction and fibrosis of those secondary pulmonary lobules. AIP is basically ARDS without a inciting cause, so you're going to see a ton of that proteinaceous fluid accumulation in your alveoli from diffuse alveolar damage with a CT scan like this. COP-BOOP is, when you rule other causes, secondary organized pneumonia is going to be likely an autoimmune attack causing a fibroinflammatory response treated with steroids. And lastly, there's smoking associated, that's COP here, COP and BOOP. And lastly, that's smoking associated ones, respiratory bronchiolitis, ILD, as well as desiccated interstitial pneumonia. These are inhalation of nasty tar substances secondary to smoking, accumulation of pigmented macrophages which are trying to clear those substances, and then secondary inflammation. That inflammation is located in your terminal bronchioles. It's going to be called RB-ILD to have those central pulmonary lobules because you're affecting, basically the center of the lobule. You're affecting your bronchi here, and that's where you get an accumulation of subsequent inflammation due to those smoker macrophages. But if it's affecting the alveoli, causing more alveolar inflammation or secondary alveolar filling, you're going to get more DIP, which is a bit worse, causes obviously more hypoxia than RB-ILD. And those are really going to be responsive to smoking cessation plus or minus steroids. If someone's hospitalized with, let's say, DIP and they're hypoxic, you're probably going to give them steroids as well. All right. And remember, these are really based on a radiographic histological pattern. They're not as much disease entities in and of themselves. They're basically this radiographic histological pattern. And once you say that it's idiopathic, not due to another cause, you can kind of say it's one of these idiopathic diffuse parenchymal lung diseases. So you may see on a CT scan, the radiologist may call it, let's say NSIP, but you really have to put it in the context. Does the patient have a malar rash? Does the patient have arthritis? Does the patient have, let's say, renal failure? Maybe it's NSIP secondary to lupus. So that's kind of confusing, but how to kind of think about these. They're just more radiographic histological patterns. Next is our autoimmune diffuse parenchymal lung diseases. I kind of really and go back actually for this one. Forgot to put the exact name of this one, but go back through to the text of MIXAP and find the question on autoimmune diffuse parenchymal lung disease, and please do that one. And then so going over autoimmune diffuse parenchymal lung disease, these are autoimmune attack, T cell antibody mediated attack of your alveoli. um, as well, and they can kind of cause different histological patterns, which subsequently correlate to different CT patterns. So you can get an NSIP pattern, if it causes more alveolar inflammation. You may get ground glass opacities. You can potentially get some fibrosis. You may get a little bit of traction bronchiectasis, but you really will not get complete architectural distortion. They can cause the UIP pattern. The ones that can do this is going to be, I think the easiest to remember, the one you'll probably only get questions on, would be systemic sclerosis. That can also cause NSIP. Remember, systemic sclerosis is really a fibro-inflammatory response secondary to an autoimmune attack. Other ones you might just have to memorize RA, and sometimes vasculitis can do it. And then you can even get a COP or cryptogenic organized pneumonia pattern as well due to interstitial lung disease. So these are the radiographic findings that you may see, and they may give you a subsequent differential diagnosis of what autoimmune diffuse parenchymal lung disease that it may be. Treatment for these is really going to be treatment of the underlying autoimmune disorder. But remember, there's a lot of other manifestations due to autoimmune diseases. SLE can cause acute pneumonitis, which will basically look a bit like pneumonia. It can be, if it's not treated, quickly with steroids, can actually lead to a lot of increased mortality. Same thing with diffuse alveolar hemorrhage. These patients may have, pulmonary renal syndrome, secondary to vasculitis or lupus. They'll come in with diffuse alveolar hemorrhage, ground glass opacities, and even subsequent consolidation of their lungs, as well as a bit of hemolysis. You can get pleuritis with pleural effusions, destruction of the bronchioles with RA, and especially, one of the more devastating things you can get is pulmonary hypertension. But these are just the patterns that you may see from autoimmune attack, from autoimmune diffuse parenchymal lung disease. And that kind of covers most of our major categories of interstitial lung disease. I made this one up myself, just trying to kind of put all the different interstitial lung diseases in my head. But your last one I just put in as miscellaneous. So the things I think about miscellaneous causes that can cause diffuse interstitial lung disease, I think of cystic. So some diffuse parenchymal lung disease, we don't use ILD anymore, can be cystic on CT scan. I think about, especially have this in your differential, if you have eosinophils on your BAL. BAL is a pretty important workup for diffuse parenchymal, DPLD, lung disease. And when you do a BAL, the things that you can kind of definitively help you with diagnosis with a BAL, one is going to be if you find a bunch of eosinophils, you may think that the patient has eosinophilic pneumonia, acute eosinophilic pneumonia, chronic eosinophilic pneumonia, or another cause of secondary eosinophilia. 2, you can rule out DAH. Do you find a bunch of blood on your BAL? If you do, start thinking that it's not diffuse parenchymal lung disease instead of being diffuse alveolar hemorrhage. If you find a ton of lymphs, mostly your differential there is going to be hypersensitivity pneumonitis, sarcoid. They both have a component of Th1 response in them, so they're going to have increased lymphocytes as well. And then sometimes you can find like foamy macrophages and amyotrophic toxicity, pigmented macrophages, and things like your respiratory RB-ILD and DIP as well. But the big things you really want to do is rule out these. And lastly, infections, right? You can do cultures on it. You can do fungal cultures. You can do smears. You can look for other atypical causes of pneumonia as well as things like TB, histoplasmosis. This could be very, very helpful to rule out infection with a BAL. So BAL is always going to be important. And if your BAL has eosinophils, you really kind of get into this differential diagnosis of eosinophilic pneumonia. And then lastly, and I made this one up myself, is going to be your alveolar filling diseases. So these probably won't, you can skip this if you're more for the high yield stuff, but these are your kind of cystic lung diseases here. So the first one we'll go over is myelomatosis, or LAM. The typical patient presentation is going to be a younger female, comes in with a bunch of cysts in her lungs. They may be complicated by rupture of the cyst with pneumothorax. She may have chylous peritoneal and pleural fluid as well. This really is due to some of these patients may have tuberous sclerosis, but they can develop it without tuberous sclerosis. But it is really genes that are involved in proliferation of smooth muscle. So here's a smooth muscle proliferation right here, and that causes this kind of cystic spaces in the lung secondary to that smooth muscle proliferation here. So the CT scan finding for this one really is going to be a lot of these small cysts, and you can kind of see here they don't have a very large, they really don't have a very large wall. They're kind of these thin-walled, kind of uniform, similar-sized cysts all the way throughout the lungs. Treatment's going to be sirolimus. Now we use sirolimus for decreasing T-cell inflammation. It's a mTOR inhibitor, but mTOR inhibition will also decrease growth of these smooth muscle cells. So it's just a little bit random, but if you do have a question where it's a young patient, a bunch of uniform cysts in their lungs, maybe they have some other findings of tuberous sclerosis, or maybe not. They could be, present without tuberous sclerosis. They'll ask you for treatment, and you'll have to know that the treatment is going to be sirolimus. Next one is going to be lymphocytic interstitial pneumonia. This one's a little bit different. Likely it's due to T-cell immune regulation, usually in the presence of a virus like HIV or Sjogren's syndrome. This is kind of your main differential here. These patients get these cysts throughout the lungs as well in the presence of one of these disorders, and they may present with dyspnea, constitutional symptoms. CT scan is going to be kind of these larger cysts. They're going to be thin-walled, but there shouldn't be as many of them classically as in someone that has lymphangiomyelomatosis. The last cystic one, usually going to be an older patient, let's say a smoker, is going to be pulmonary Langerhans cells histiocytosis, or PLCH. What's going on with these patients is they have cigarette smoke, likely causes mutations, and the mutation that's been found now is going to be BRAF, which is a secondary cellular signaling mutation and involved in growth and proliferation, in this case, of dendritic cells. So you have all these dendritic cells here, and these dendritic cells proliferation here can subsequently cause these cysts. Because you have that big dendritic cell proliferation, you might have these irregular walled cysts here. You might even just have the proliferation of the dendritic cells here with even nodules as well. You're going to need a lung biopsy. You're going to have to stain really for CD1A, and that CD1A is a marker for Langerhans-like cells as well. Just like patients that have, IPF is associated with smoking. Obviously, your smoking-associated idiopathic diffuse parenchymal lung diseases like RB-ILD and DIP have associated with smoking. Just like all of them, anything with an association with smoking, you really got to stop smoking. So these patients, first line is stop smoking. You may end up giving glucocorticoids, and because this is a proliferation of abnormal cells and almost neoplastic in a way, it's really refractory. You might actually even need to treat it with chemotherapy, things like cladribine or cytarabine. Next is going to be your pulmonary eosinophilia, diffuse parenchymal lung diseases. Anytime I think of eosinophilia, I think of the pneumonic China. So things that can cause eosinophilia would be collagen vascular disease, Hellman's, idiopathic neoplasm, allergic, atopic as well. So in that, EPGA, if you have a patient with, let's say, and mostly you're going to diagnose this with a BAL. Some of these will have eosinophilia on their CBC with differential, but some of them, actually may not, and just have eosinophilia that's just associated with the lungs, especially these. They made these, acute eosinophilic pneumonia, as well as chronic eosinophilia. You may not have peripheral eosinophilia, so you can't make the diagnosis that way. If the patient comes in with a history of asthma, joint pain, maybe they have, systemic signs of small vessel inflammation with nerve infarctions. They can have these patients may have mononeuritis multiplex. They may have signs of small vessel vasculitis with capillary inflammation and rupture with purpura. And on the lung exams, a lot of times they'll have these kind of fleeting interstitial infiltrates in the setting of worsening asthma. Your thought should be EPGA, eosinophilic polyangiitis with granulomatosis. These patients may need steroids in response to this. Maybe if the patient has a history of travel, or especially if they're from an area where helminths are pretty prevalent, which is more commonly really near the equator in these areas here. You want to think, could they have transpulmonary passage of worms, things like strongyloidiasis, ascariasis, hookworms, or even filariasis, other rare tropical diseases can cause pulmonary eosinophilia as well. So something you might have to work up in those cases, or even consider empiric treatment with ivermectin or albendazole, especially if you're going to give those patients steroids, because strongyloidiasis, if you give steroids to them, they can actually get worsening of the disease with hyperinfection. Idiopathic causes, these are, I think, still categorized as diffuse parenchymal lung diseases, so acute eosinophilic pneumonia. These are a lot of times inflammatory Th2 responses, acute to things like smoke and dust inhalation, or chronic eosinophilic pneumonia. I had seen this once in a patient that had really just severe refractory pneumonia and severe refractory asthma, came to the hospital and just had these atypical lung infiltrates. We treated with antibiotics. We thought it was maybe a viral or bacterial pneumonia causing an inflammatory response. She didn't get much better, and eventually we had to give her steroids, and that actually improved her lung function, improved her hypoxia. Next is neoplasm. So neoplasms can do it in a couple different ways. I will say, these are kind of in primary or secondary. So in primary, a lot of times there's a mutation going on here. So specifically with one of the hypereosinophilic syndromes that you may get a question on, it's due to a mutation with, I think it's like FLP and PDGFR. But anyway, these patients get a monoclonal proliferation of eosinophils. Most of these patients are going to have peripheral eosinophilia, and not just lung eosinophilia, and they can have signs of eosinophilic damage of certain parts of the body. So they might have eosinophilic myocarditis. Here's a MRI of the heart that you can see there's endocardial inflammation here, secondary to eosinophilic inflammation and release of those like myelin basic granules and proteins that cause damage. They may show up with rash, and secondary they can show up with pulmonary eosinophilia, but mostly they're going to have a systemic response with eosinophilia. So it can be a primary response due to a mutation causing worsening eosinophilia, or sometimes lymphoproliferation can do it as well. So lymphocytes proliferate. They're abnormal, so they secrete things like IL-4, IL-5, and they can get secondary eosinophilia from that. So always reasonable to do like a flow cytometry. If you're worried about this, then look for it to see if there's a monoclonal proliferation of lymphocytes. Lastly, allergic atopic, APGA, allergic pulmonary. What is this? Allergic pulmonary granulomatosis. Oh no, allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary. Sorry, did that wrong. ABPA, allergic bronchopulmonary aspergillosis. A lot of times this is a patient who has asthma. I don't know if this is true, but I always think that they're having a lot of inhaled glucocorticoids. From those inhaled glucocorticoids, they have kind of like mucosal immunodeficiency in the lungs. They can get a secondary growth of aspergillosis in the lungs and have a hypersensitivity reaction to that. These patients are going to come in with kind of that asthma plus syndrome, refractory asthma, and because they have aspergillosis, they may even and they get mucoid impaction, subsequent inflammation of the airways, dilation of the airways in response to that. They can have bronchiectasis as well. So you might, if you see that, as well as you have antibodies to aspergillosis as well, and elevated IgE, eosinophilia in the setting of kind of refractory asthma, you really want to think about APPA. And lastly is going to be Th2 responses to drugs. The biggest one, most concerning, is going to be DRESS. So DRESS response is really a Th2 systemic response to a medicine, can be pretty deadly. These patients can get things like pharyngitis. They can get hepatitis, so damage of their liver as well. A lot of times they'll have that maculopapular rash that you see with drug reactions, but the things that really puts this patient in address is having organ inflammation secondary to eosinophilia, which can sometimes affect the lungs. Here you kind of see a little bit of a ground glass opacity inflammation from eosinophilia in the lung, and even a little bit of like hate. Almost looks like crazy paving here, which we'll go into our next disorder, which is alveolar filling. So these are things that really cause complete filling of the alveoli. So not only are they filling the alveoli, they're also kind of depositing and causing like interlobular septal thickening as well. These things are cool because you actually see kind of perfect outline of your secondary pulmonary lobules, secondary to that interlobular thickening, which we see, let's say, I don't know, here, interlobular thickening here, as well as some filling, partial or full filling of those alveoli here. Things that can do this is going to be pulmonary alveolar proteinosis. Really what this is that it's an alveolar macrophage's function. The macrophage in the alveoli are really important for clearing surfactant. Sometimes you can get reduced GM-CSF really from like antibody attack. The GM-CSF, that decreases and it kills or decreases production in the macrophages in the alveoli. And when there's no macrophages, the surfactant subsequently builds up. When that surfactant subsequently builds up, here's your normal alveoli. It causes this kind of PAS positive surfactant in the patient's alveoli, and that this can really make them come in with things like hypoxia, shortness of breath, but a lot of times they really won't have a lot of constitutional symptoms. They may have a background of, let's say, hematological malignancy, and they're trying to get rid of this malignancy, so they're creating an immune response to it with antibodies, secondary to things like GM-CSF, things like leukemia, but then that can subsequently kill the macrophages in the lungs, causing the surfactant buildup. The BAL here, another good finding of BAL and why it's so important for DPLD is that it's going to be PAS positive. So PAS is going to be positive for this surfactant buildup, and you might see this milky, opaque fluid, which is that surfactant. Treatment is going to be supportive care. In the ICU setting, sometimes there has been response with whole lung lavage, basically putting water down there, sucking it back up, putting water down there, sucking back up while doing a bronchoscopy. And, because it's deficiency in GM-CSF, giving GM-CSF, getting those macrophages in your alveoli, which they then subsequently clear the surfactant, can be pretty helpful. Clinical trials can be good too. Lastly, is going to be lipoid pneumonia. So in this case, these patients really have aspiration of oil, mineral oil. Sometimes this has been seen with e-cigs. Certain times when people that took e-cigs and presented with hypoxia, in certain cases this was actually due to lipoid pneumonia, and these patients can get recurrent dyspnea and cough. You can kind of see the outline of the secondary pulmonary lobules here, as well with that kind of crazy paving. And crazy paving is not just going to be alveolar filling disease. You can see crazy paving in other things as well. Things like lymphatic carcinomatosis, which is spread of lymphatics in the lungs of cancer. You may see this. You may see this with heart failure sometimes if you have pretty severe pulmonary edema as well. So it's not super specific to it, but this may be on your differential, especially if you don't think the patient has an inflammatory response. Viral pneumonias can do this as well, heart failure or malignancy. This one's kind of interesting. So, once again, alveolar filling. But on the CT scan, sometimes you can actually see that there is some fat really here, right? So these patients may have foci of fat attenuation on their CT scan, and that can really be a clue that they have lipoid pneumonia. And here's a normal alveoli, and what you're going to see, if they do need a biopsy, is basically fat filling or lipids kind of filling those alveolar spaces. And then it may stain positive with red O staining as well. Treatment obviously is going to be avoidance of the insult.
workup with aspiration in general. Why are these patients aspirating as well? They may need a modified barium swallow, speech consult, and then plus minus steroids, but it's kind of mixed. And that kind of finishes all of, sorry, this was an old lecture, I still have ILD up here, of the diffuse parenchymal lung diseases. Just remember that you want to consider things like pulmonary edema, which can cause ground glass opacities, crazy pavings, infections, which can cause the same things. Same thing, aspiration, which can cause things like consolidation, and malignancy, which can cause ground glass opacity, especially in adenocarcinoma or lymphoma of the lungs, can cause crazy paving, especially with lymphatic spread of cancer. So rule these things out, consider these things. Maybe you need a BAL with biopsy. If you really don't think it's secondary to these, these are kind of buckets with granulomatous response. You might see that bronchovascular nodular thickening with mediastinal lymphadenopathy. Inhalation with hypersensitivity pneumonitis, you may see ground glass opacity, central lobular nodules. You may see, because it affects the bronchi, you might see that the patient has blockage with expiration, expiratory air trapping. Your BAL with greater than 20% lymphocytes is going to be helpful here. Inorganic with their pneumoconiosis, do they have fibrosis? In asbestosis, do they have pleural-based plaques with asbestosis? Do they have central lobular nodules with silicosis, fibrosis, eggshell calcifications, and what was their work exposure? Always asking about that. Iatrogenic, remember drugs can be acute. They can almost present like ARDS or pneumonitis, or they can be chronic, especially with things like bleomycin and nitrofurantoin and amiodarone with lung fibrosis. Radiation as well. Kind of see a picture here with here's that radiation port, went this way, and that's where the fibrosis is happening. Sometimes patients with previous radiation, when they get chemotherapy, they can kind of present with lung inflammation in that radiation area called radiation recall. Autoimmune, basically the full gamut of autoimmune disorders can cause can cause DPLD. They may have different histopathic, pathologic, and CT findings. Here's a patient with lupus with more of an NSIP pattern with that ground glass opacities in the basal lower lobes, idiopathic, acute interstitial pneumonia, which is basically ARDS of unclear cause, NSIP, which is more that inflammation, mostly of the alveolar septi, but can subsequently get some fibrosis, though not complete architectural distortion like you see with UIP, with honeycombing, which you see all here. If you see honeycombing, you think it's more UIP. If it's UIP, and you don't find a cause like hypersensitivity pneumonitis or a cause of fibrosis like HSP, drugs, autoimmune attack like systemic sclerosis, you can call it IPF. COP or BOOP, it's going to be that fibroinflammatory response with like alveolar and bronchiolar filling of fibrin, and RBILD and DIP is secondary to inhalation of toxic substances, accumulation of macrophages, subsequent inflammation of these macrophages, subsequently causing inflammation as well. If the inflammation is more the terminal bronchioles, you'll see that central lobular nodules from that center of the terminal bronchial inflammation. If it fills the alveoli, you might see ground glass opacities, consolidations, and it's called disquamative interstitial pneumonia, or DIP. And lastly, your miscellaneous causes. You get eosinophils on your lungs, on your BAL. Think about eosinophilic causes. The ones that are diffuse parenchymal lung diseases would be acute eosinophilic pneumonia, chronic eosinophilic pneumonia. If you see cysts in a young patient, woman, think about LAM. If it's a patient with HIV or maybe drugs, HIV or Sjogren's syndrome, think about lymphocytic pneumonia, LIP here. And if it's older patient, smoker, with kind of thick lung cysts everywhere, think about pulmonary Langerhans cells, histiocytosis. And if you see crazy paving, there's a differential, here. These can also cause crazy paving, but think about if those aren't all differential, think about things that cause alveolar filling, pulmonary alveolar proteinosis or lipoid pneumonia. And that is it. Thank you.